Hello, everybody, and welcome to our module on EKG Basics. So to understand an EKG, you have to understand how electrical activity moves through the heart. So let's review that process right now. So for each cardiac cycle under normal conditions, the electrical activity begins in the SA node. That's the pacemaker of the heart. From there, electrical activity moves in both directions to depolarize myocytes in the atria and cause the atria to contract. But there's only one way for the electrical activity to reach the ventricles, and that's by going through the AV node. So after the atria have depolarized, electrical activity will move through the AV node, then through the His bundle, then through the two right and left bundle branches, and finally, electrical activity will reach the Purkinje fibers. These fibers penetrate the myocardium, and so they will depolarize the myocytes in the left and right ventricle, and that's what will cause the ventricles to contract. And so that's how electrical activity moves from where it starts in the SA node all the way to the right and left ventricles. So all that electrical activity we described on the last slide can be detected by the leads of an EKG machine. Based on the electrical activity they detect, they can create an image of the cardiac cycle that looks like this. To understand how an EKG lead works, you have to appreciate that they're placed around the chest at different locations, which we'll talk about in more detail later. And then each lead looks at the electrical activity from its own specific location. So for example, let's imagine that we had an EKG lead right here. It would detect electrical activity in the heart. And anytime it detected electricity moving towards it, it will create an upward deflection from baseline in the EKG tracing. Anytime it detects electrical activity moving away from it, it will create a downward or negative deflection. And so based on the upward and downward deflections from electrical activity it detects, it can create an image like what's shown here. And each of these bumps and lines in the image represents different electrical events in the heart. So the first wave you see in a normal cardiac cycle is called the P wave. It's a small bump, and that's created by the electrical activity when the atria depolarize. Remember I said all these atrial myocytes depolarize so that the atria can contract? That's what makes the P wave happen right here. After the P wave, there's a brief pause where there's a relatively low level of electrical activity. And the reason for that pause is because it takes time for the electricity to move through all the conducting structures in the heart. First of all, the AV node, but also the His bundle, the bundle branches, and the Purkinje fibers. Once the electrical activity leaves the Purkinje fibers, it depolarizes the ventricles here. And that depolarization is what causes this big up and down structure in the middle called the QRS complex. The QRS complex can have an initial downward deflection, and if it does, that's called a Q wave. Not all EKG leads have a Q wave. We'll see that in a minute. And then the first upward deflection is called the R wave, and the downward deflection after the R wave is called the S wave. And this whole thing is called the QRS complex, created by electrical activity moving through the right and left ventricles to cause depolarization. Then finally, the last little bump we have on an EKG lead depicting the cardiac cycle is the T wave, and that's caused by the ventricles repolarizing after they have depolarized. So after this whole thing occurs, we've gone through an entire cardiac cycle of all the electrical activity being conducted to the atria and ventricular myocytes so that all four chambers can contract and pump blood. So shown on the screen is a typical so-called 12-lead EKG, and it gets this name because it has 12 leads. This is lead 1, lead 2, and lead 3. Then we have leads AVR, AVL, and AVF. And then finally, we have the 6 chest leads. They get this name because the stickers for the leads are placed directly on the chest, and these are leads V1 all the way through V6. And then if you look in closely at one of these leads, for example, I've blown up lead 2 at the top, you can see all the things we talked about on the last slide. You can see a P wave, a QRS complex, and a T wave, and then there's a pause, and then it happens over again and over again. And many times an EKG lead will have a couple so-called rhythm strips along the bottom, like what's shown here. In a rhythm strip, you pick a lead, like for example, this is V1 or this is lead 2, and you just show multiple beats in a row. And the idea here is to just give the reading physician an idea of if the beats are varying with some coming early and some coming late. It's easier to see that if you have more beats to look at. But basically what we've got here are 12 different electrical leads, 12 different little eyeballs looking at the electrical activity of the heart and depicting it in this image of the EKG. So every one of those 12 leads is watching the same electrical activity. It's watching the SA node depolarize and send electrical activity to the atria. It's watching the electrical activity move through here to the Purkinje fibers and into the ventricle. But because some leads are positioned over here and some leads are positioned over here, the QRS complexes and the P waves and the T waves can look different in the different leads. They're all looking at the same activity. They're all looking at the heart as it depolarizes and goes through a cardiac cycle. But whether or not the different waves are up or down or negative or positive depends on the vantage point of the lead. Just to make this super clear, imagine two people were watching this car move down the street. Person one would say, oh, the car's coming towards me. Person two would say, oh, the car's moving away from me. They're both correct. They're just watching the car move from different vantage points. So if we go back to this slide, this QRS complex here in lead 1 is the same electrical activity depicted by the QRS complex in lead V6. All these leads are looking at the same thing. But you can see in lead 1, the QRS complex is mostly positive with a little downward wave. But then in lead 2, it's all positive. There's no downward wave at all. And then over here, for example, in V2, we have a little bit of an upward wave, but a much bigger downward wave. So you can see if you just focus on the QRS complexes, how they all look different, but they're all looking at the same thing just from a different vantage point. And so shown on this slide is how the different EKG leads look at that summation vector of the ventricular myocytes depolarizing. Remember, it's going like this. So for example, AVL is going to look at it and see the wave coming mostly towards it. On the other hand, AVR will look at it and see the wave going totally away from it. Down here at the bottom, we have inferior leads that will see electricity moving towards it. V1 will see some activity move towards it, but then other activity moving away from it. You get the idea. And so because all these leads are looking at different vantage points, they will all have the QRS complex pointing in different directions. And so you can see what I'm talking about here. Lead AVR has the QRS complex going entirely downward. On the other hand, lead V5 has the QRS complex going entirely upward. This is because of the different points of view of the two electrical leads, even though they're looking at the same thing. So that's a basic principle of a 12-lead EKG, is that it shows you 12 vantage points of the electrical activity in the heart. But each time you see a P wave and a QRS complex, it's showing you the same thing just from different points of view. So in this slide, I've summarized the key principles of EKGs that I've been talking about. So the different waves like the P wave and the T wave and the QRS complex, they all represent repolarization or depolarization of different structures in the heart. And then most EKG leads, traditional EKGs, have 12 leads, but each lead is watching the same thing just from a different vantage point. And when the lead detects electrical activity moving towards it, that causes an upward deflection. Away from it causes a negative deflection. Okay, now let's talk about the pacemakers of the heart. So pacemakers are electrical structures in the heart that are capable of generating electricity to start a cardiac cycle. And as I mentioned before, in normal hearts, the SA node is the dominant pacemaker. That means it paces the fastest, and because it's generating electrical activity faster than any other pacemaker, it ends up controlling the whole process. There are other pacemakers outside the SA node, but they are slower. So under normal conditions, their depolarization is controlled by the SA node. They are not causing depolarizations on their own. But if the SA node fails, and this sometimes happens in a number of disease states, other pacemakers can take over. So for example, the SA node, which is the normal pacemaker of the heart, at rest usually paces the heart at 60 to 100 beats per minute. But the AV node can also pace the heart if something happens to the SA node. However, it can only do so at 40 to 60 beats per minute. But then if there's a problem with the AV node, the His bundle can actually pace the heart, but it can only do so at 25 to 40 beats per minute. And then finally, the bundle branches and the Purkinje fibers can also pace the heart, but at a much slower rate. So in disease states where the SA node fails or the AV node fails, luckily, that doesn't mean our hearts stop and we die. These other slower pacemakers will take over to keep the heart functioning. They just can't do as good a job as the SA node normally does. Let's talk about conduction velocities, which means how fast electrical activity moves through the heart. So it's super high yield to know that the slowest conduction velocity is through the AV node. This is an evolutionary thing. The AV node evolved to slow down the electrical activity to give time for the ventricles to fill with blood from the atria. If we didn't have our AV node, the ventricles would contract when the ventricles were only a quarter filled with blood, and that would be much less efficient than the heart that we have. The fastest conduction is in the Purkinje fibers, and then conducting through the atria and the ventricular myocytes is in the middle. Now let's talk about how you determine the heart rate from an EKG tracing. There are many, many ways to do this. I'm going to show you the way I was taught and that I always use, but you can look online and find other ways to do this as well. So the way I've always determined a heart rate is by counting the big boxes between QRS complexes. Let me explain what I mean by that. If you look closely at this drawing here, you can see that there are big boxes and there are also small boxes. Each big box represents 200 milliseconds and each small box represents 40 milliseconds. So the way I've always determined the heart rate is I find a QRS complex that starts on a dark line, in other words, starts at the beginning of a big box. And then I look to see where the next QRS complex is. If the next QRS complex were one big box away, then the heart rate would be 300 per minute. If the next QRS complex were two big boxes away, then the heart rate would be 300 divided by 2, or 150. If the next QRS complex was three big boxes away, then the heart rate would be 300 divided by 3, or 100. And then our QRS complex is almost four big boxes away, so that's a little bit more than 300 divided by 4, or 75. So we have a heart rate on this EKG close to 75. And a helpful rule of thumb that I've always used is that 3 to 5 big boxes between QRS complexes usually indicates a normal heart rate. When the QRS complexes get closer together, that means the heart rate's going up. When they get further apart, the heart rate is slowing down. Okay, now let's talk about the QRS axis. So remember that I told you earlier that the QRS complex is generated by depolarization of the ventricular myocytes. Well, if you look at this drawing here and remind yourself of what the heart looks like, you know that ventricular myocytes are found in all different places. So there's some out here, there's some in the septum, there's some in the right ventricle, and then the right ventricle has fewer myocytes than the walls of the left ventricle. So basically, when the ventricular myocytes depolarize, you get a lot of different electrical activity moving in different directions. But if you could sum up all that electrical activity, it would look something like this. It would look like electrical activity moving down and to the right side of the heart. And that's because there are more myocytes in the left ventricle, so that sort of pulls the overall summation electrical activity away from the right side and toward the left side. And so this axis, the angle at which this summation vector of electrical activity generated by the QRS complexes and the ventricular myocytes, that summation vector is called the QRS axis. So if we could take a big plus sign and slap it right over the heart, we would get something that looks like what's on the screen here. And if we determined that QRS axis, that summation vector of electrical activity of the QRS complexes, it would look something like this. It would be down here, normally found between minus 30 and plus 90 degrees. And so now we're going to talk about how to determine the QRS axis, but the idea here is that if you've got a normal heart with a normal number of myocytes and they're all healthy, the QRS axis should work out to be somewhere in this range here. But if you had an abnormal heart where things weren't functioning normally, you could get a QRS complex that's going up into this quadrant here, and that's called left axis deviation. And there are a number of causes of left axis deviation, but two classic ones are a left bundle branch block or a ventricular rhythm. A ventricular rhythm is a rhythm being generated by a pacemaker in the ventricles. It happens in very sick hearts where the ventricles are abnormal. And that's one of the things, along with left bundle branch block, that can pull the QRS axis up into this quadrant. If the QRS axis gets pulled down into this quadrant, like the green line I've shown here, that's called a right axis deviation. And there are a list of things that can cause right axis deviation. Two important ones that I think are worth knowing are a right bundle branch block will cause the axis to deviate to the right. And if you have a hypertrophied right ventricle, that will leave more myocytes on the right side of the heart, and that can also cause the axis to deviate over to the right side. Okay, now that we understand what the QRS axis represents, we understand that normal is between minus 30 and plus 90, but the QRS axis can move leftward or rightward in certain disease states. Now let's talk about how you look at a specific 12-lead EKG and determine the axis. So in order to do this, we're going to have to look at leads 1 and lead 2, and we're going to have to determine the vector for their individual QRS complex. Let me explain what I mean by that. So imagine that lead 1 had a QRS complex with a big, tall R wave and then a very small S wave. Well, the big, tall R wave would represent a positive line like this, and the small S wave a negative line like this. And if we add these two together, we would still get a positive line, but just not quite as big. So that's the summation vector of the QRS complex in lead 1. On the other hand, if we had a lead that went like this would give us a summation QRS vector more downward. So basically what you want to start to do to determine the axis is look at leads 1 and 2 and determine if overall the QRS complex is pointing up or down, and then how much it's pointing up or down by. Once you do that, you can go back to this little diagram in the middle of the screen here, and for lead 1, you're going to make a line in this direction if it's positive, a line in that direction if it's negative. And then the size of the line is determined by the size of the QRS vector for that lead. For lead 2, if it's positive, you're going to go down in this direction, and if it's negative, you're going to go up in this direction. And so once you have two lines, a line created by lead 1 and a line created by lead 2, you add them together, and that will tell you where the QRS axis lies. Now, in your med school classes, you may actually measure the height of the QRS complex and actually create a triangle and determine the specific QRS axis. But in real life, no one does that. Everyone uses the quick method to determine the QRS axis, and that's what I'm going to show you now. So to use the quick method, the first thing you do is you glance at lead AVR. AVR is an unusual lead in that it's always negative in everybody, assuming things are normal. So you look at AVR first as a quality control. It should have a negative QRS complex like this. If it doesn't, it usually means the leads have been reversed. Someone's put the stickers in the wrong place. So the first thing you do to use the quick method for determining axis is glance at lead AVR, basically for quality control. The next thing you do is you look at leads 1 and leads 2, and if they're both upright and positive, then the axis is normal because the axis lies between 0 and 90. Remember, we saw that plus sign before, and lead 1 pointed us out in this direction if it's positive, lead 2 in this direction. So if they're both positive, the axis lies somewhere in this quadrant, and all the values in this quadrant are normal. So for most of the EKGs you look at, if patients are normal, you're going to see an upright QRS in lead 1 and 2, and you're going to immediately know the axis is normal. If you want to know whether there's left axis deviation, all you need to do is look at lead 2. When there's left axis deviation, lead 2 will be negative, like what's shown here. Lead 1 will still be positive, like under normal circumstances. So if you remember our little plus sign from before, positive lead 1 pushes us out in this direction. A negative lead 2 pushes us up in this direction. So when you have a negative lead 2 and a positive lead 1, QRS axis is going to be somewhere up here. And remember, anything from minus 30 all the way to minus 90 is left axis deviation. So what this means is when you have lead 1 like this and lead 2 by this, you are very leftward and definitely have a left axis deviation. There is one exception to this. If lead 2 looks like this, where it's halfway up and halfway down, that's called a physiologic left axis. It means that the patient's axis is 0 to minus 30, which is still within the normal range. So the bottom line here is a very negative lead 2 with a positive lead 1 is what you're looking for left axis deviation. If you want to know whether there's right axis deviation, all you need is lead 1. If lead 1 is negative, then you have right axis deviation. Once again, remember our plus sign here. A negative lead 1 points us in this direction, and then a positive lead 2 points us down here. So if we've got these two findings, our summation axis is going to be down in this quadrant, which is right axis deviation. And so I've summarized the major points of the quick axis method. First, look at AVR for quality control. It should be negative. Then you look at leads 1 and 2. If they're both positive, the axis is normal. If lead 2 is negative, you have left axis deviation. If lead 1 is negative, you have right axis deviation. The one exception to these rules is the physiologic left axis, where lead 2 is partly up and partly down. So if you're going on a rotation and you think you're going to be asked to identify the axis on an EKG, learn this quick method. You can glance at the EKG, just look at leads 1 and 2, and you'll be able to know what type of axis you have. Okay, now let's switch gears and talk about some of the important intervals you can measure on the EKG. We'll start with the PR interval. So the PR interval is the amount of time it takes from the beginning of the P wave to the start of the QRS complex. And a normal PR interval is 120 to 200 milliseconds. And remember what I told you, the big boxes are 200 milliseconds apart. So basically, the start of the P wave to the start of the QRS should have about one big box or less of space involved. And if you see that, you have a normal PR. Sometimes the PR interval gets prolonged. If you look at this one here, it starts here and goes here. It's more than one big box in width, so it's prolonged. And one of the classic things to cause a prolonged PR interval is first-degree AV block. I talk about this in other videos, but remember the PR interval represents the time for electrical activity to move through the AV node. So if conduction through the AV node is slowed, that will stretch out or prolong the PR interval. And then the classic cause of a short PR interval, which you should know for your board exams, is Wolff-Parkinson-White syndrome, which we'll talk about in another video. But if you look here, this is the PR interval. It's very short, and it's because you have a delta wave of WPW right here, causing the QRS complex to begin early. Okay, next let's talk about the QRS interval, which is the amount of time from the start of the QRS complex to the end of the QRS complex. Normal is less than 120 milliseconds, which is 3 small boxes because small boxes represent 40 milliseconds each. The two classic causes of a prolonged QRS interval are the two bundle branch blocks. When you have a right bundle branch block or a left bundle branch block, those will cause the QRS complex to get prolonged. If you look at this one in the bottom right, it starts here, doesn't end until about here. It's close to 200 milliseconds or one big box in width. And the bundle branch blocks are classic causes of a prolonged QRS interval. And I talk about them in detail in another video. Okay, next let's talk about the QT interval. That's the amount of time from the beginning of the QRS complex to the end of the T wave. And it's hard to give you a normal range for that because the QT interval changes with heart rate. It's different for a heart rate of 60 compared to a heart rate of 100. So on your board exams, they're probably not going to ask you to measure the QT interval and know whether it's prolonged or shortened. But they will want you to know some of the causes of short and long QT intervals. So the short QT interval is classically caused by hypercalcemia. We'll talk more about that in a second. A prolonged QT interval can be caused by hypocalcemia. There are also a number of drugs that cause the QT interval to prolong. There's also something called the congenital long QT syndrome. And I'll talk about all these things in the next few slides. Before I go on, I just want to point out the QT interval here is very short, and the QT interval here is much, much longer, just to give you an idea of what a short and long QT interval looks like. In the video on cardiac action potentials, I talk about the myocyte action potential, and I talk about how phase 2 is caused by calcium going into the cell and potassium coming out of the cell. Well, when there's high potassium from hypercalcemia, it drives calcium into the cell faster and it shortens this action potential duration. And that's why the QT interval shrinks in hypercalcemia. The opposite happens when there's hypocalcemia. It's all tied into this myocyte action potential in phase 2. When the QT interval becomes prolonged, it can be dangerous because it puts the patient at risk for a form of ventricular tachycardia called torsade de Pointes. This is an image of what it looks like here. Torsade de Pointes means twisting of the points, and it gets this name because the points of the QRS complexes are twisting, meaning they're going up and down over the course of the EKG tracing. And this is the feared outcome when a patient has a prolonged QT interval. It can allow this arrhythmia to occur, and this arrhythmia often leads to cardiac arrest and death. So what can cause QT prolongation and lead to this arrhythmia? Well, there are a number of antiarrhythmic drugs that prolong the QT interval, and this is one of the reasons why those drugs are dangerous. You can also get prolonged QT when you have low potassium, low magnesium, and as we already talked about, low calcium. It's very rare for low calcium to actually cause torsade de Pointes, but hypokalemia and hypomagnesemia definitely do. There is a rare condition called the congenital long QT syndrome, where affected individuals are born with a prolonged QT interval and they're at high risk of torsade de Pointes throughout their whole lives. It's a genetic disorder and it's related to abnormalities of the potassium and sodium channels. So once again, going back to the cardiac myocyte action potential, this phase of the action potential is caused by a sodium influx into the cell. It requires sodium channels. And this phase here is caused by potassium exchange and requires potassium channels. So if you have abnormal sodium channels, then this phase can be drawn out and take longer to occur. If you have abnormal potassium channels, this phase can take longer to occur. Either of these things, delaying and prolonging the myocyte action potential, will stretch out the QT interval. Because remember, the QT interval represents the time for myocytes to depolarize beginning here and repolarizing at the end of the T wave. If they describe a patient with the congenital long QT syndrome on your board exams, they'll probably say that the patient has a family history of sudden death, and that's because other family members have the long QT syndrome and some have developed torsades. They also may say that the patient has recurrent seizures because long QT syndrome is often misdiagnosed as seizures when the patient passes out from torsades. But if they describe a young patient with seizures and the EKG shows a long QT interval, you need to think that they may not actually have seizures. They may be fainting from torsade de Pointes. And then there's a rare variant of the congenital long QT syndrome called the Jervell and Lang-Nielsen syndrome. This syndrome stems from a family that lives in Norway and Sweden, was discovered to all have the congenital long QT syndrome as well as congenital deafness, and that gave rise to this name. It's basically a syndrome of the long QT plus congenital deafness. So in my whole career, I've never seen a congenital long QT syndrome patient, but I've seen hundreds and hundreds of patients with an acquired long QT syndrome. This is far more common. So there are many drugs that can cause the QT interval to become prolonged. I mentioned antiarrhythmic drugs before, but some others that you should know are levofloxacin. It's an antibiotic, Paldol, which is an antipsychotic, and then there are many, many other drugs. And for patients who have the congenital long T syndrome, many of them carry around a list in their pocket of all the drugs they need to avoid, because if they're ever accidentally given one of these, their QT can get longer and they can die from torsades. Let's briefly talk about T waves. So the T waves shown on this image on the screen are very tall. These are called peak T waves. You can see this in patients who have hyperkalemia. Many people remember that potassium hides under the T wave to remind them that it can get tall when there's hyperkalemia. You can also see T waves in very early ischemia, very early myocardial infarctions. These are called hyperacute T waves, and they look very similar to the peak T waves of hyperkalemia. And then I'll finish this video by talking about U waves. So a U wave is an upward deflection on the EKG tracing that occurs after the T wave, but before the next P wave. And you can see U waves in many normal patients, but they also occur in some pathologic conditions. Two that are well described are hypokalemia patients can have U waves, and bradycardic patients can also have U waves. But like I said, they're present in many normal patients, and they don't necessarily mean the patient has any pathology. Nobody knows exactly what causes the U wave, although they're believed by many theories to represent repolarization of the Purkinje fibers, but nobody really knows. And usually you see them in V2 to V4, just like this example here. You're seeing a U wave in V2 and V3. And that concludes our module on EKG Basics.